Hi, this is Genevieve Morris. I'm the Senior Director of Health IT Policy here at AI, and we appreciate you all joining us today for our first in a series of webinars called Breaking Down the QPP. So today we're going to be focusing on MIPS at a glance. Let me go to the next slide really quick. Just let everyone know the webinar is being recorded. We are also providing the slides to folks. You actually should have seen it just pop up as a handout in the webinar itself, and then of course it'll be available online after the fact. Next slide. For those of you who may not be familiar with AI, we are a health information technology and policy company located in the DC area, and we do a lot of work both with private organizations such as health information exchanges, as well as a lot of work with the Office of the National Coordinator around a lot of these programs. So as I mentioned, this is the first in a series. So today we're focusing in on MIPS, and it will be obviously a condensed version. For those of you who may have looked at the rule, it's all 2,000 and some pages of it, very long, and so we've tried to condense that down into some of the things that we think are most important for the audience. The second webinar is going to focus in on the health IT needs to support advanced APMs, and so that will focus in on some of the rule requirements for advanced APMs, as well as some of the health IT framework items. And then our third webinar is going to focus on how health information organizations can support MACRA. And we're actually going to add a little bit to that one. The 21st Century Cures Act just got passed through Congress this week, and the President is expected to sign it shortly. And so we're also going to talk a little bit about some of the implications of the 21st Century Cures Act, in particular for health information exchanges. So this is our speaker today, so I'm moderating the call, and Kory Mertz, who's our senior manager, is going to be presenting. Kory has been with AI for about 1.5 years. He was previously with the Office of the National Coordinator, working in the Office of Policy, so very familiar with the Meaningful Use program, and a lot of that transfers over into the Quality Payment program. And here at AI, he's done a lot of work with health information exchanges, working with health systems to help them in the Meaningful Use program, and is currently supporting the new QPP program. I'm going to hand it off to Kory to take over from there.
Great, thanks, Genevieve. Welcome, everybody. Excited to talk to folks today. As Genevieve mentioned, we're going to do a quick overview of the MIPS program, provide you kind of the big key pieces, particularly areas where the final rule made changes. And then we're going to reserve a little time at the end for questions. So the Merit-Based Incentive Payment Program, that's MIPS. You know, as most folks know, MIPS is really sunsetting 3 existing programs and rolling them up into one program. So it's replacing the Physician Quality Reporting Program, the Value-Based Payment Modifier Program, and then for eligible professionals, the Medicare Meaningful Use Program. You know, Meaningful Use is still in place for hospitals and Medicaid eligible professionals. The important thing to keep in mind that gets glossed over in a lot of these conversations. But all these programs sunset next year. They're going to be wrapped up into MIPS moving forward. So the payment adjustments will no longer apply from those programs. So who's included? Nothing really changed here in the final rule. This is really, you know, same stuff as what was in the proposed rule. I think the main thing to highlight here in 2017 and 2018, for folks who are particularly familiar with the Medicare Meaningful Use program over the years, having nurse practitioners, physician's assistants, you know, nurse specialists, and CRNAs as part of the program is different. They were a lot of them were eligible under the Medicaid Meaningful Use program, but they, you know, the participation kind of varied across states, and they weren't necessarily active participants. So it's a new group to think about and to worry about, particularly for the ACI category, which has replaced Meaningful Use. And also just a reminder, in 2019, the Secretary has the authority to expand you know, the types of providers that fall under the MIPS program. So again, all that's laid out here. I'm happy to talk through any of that in the question period. So on the exclusions, CMS established 3 exclusions. The one that really changed here was the low volume threshold. So previously, the threshold was set at $10,000, and you had to have less than 100 Medicare patients to be excluded for a low volume threshold. CMS changed that. They increased the dollar low volume threshold to $30,000, and instead of having it be an and, they changed it to an or. So if you either have under $30,000 in Medicare payments, you're excluded, or if you see less than 100 Medicare beneficiaries in a performance period, you are excluded as well. So that's a big change. The other thing they did, based on comments, a lot of commenters pointed out it's really hard if we don't know if we're excluded from the program during until like the end of the performance year. Makes it really hard to plan, right? Because you're going to have to plan for actually meeting MIPS because you have no idea if you're going to be excluded or not. So they made a tweak there. So they now have two 12-month periods they're going to look at to determine the low volume threshold. So for 2017, the first will be looking from September 1, 2015 through the end of August 2016. So that'll be the first period. If you meet either of those low volume exclusions during that period, you're going to be excluded from the payment adjustments for the 2017 performance period. The second period they'll look at is September 1, 2016 through August 31st, 2017. So that period will be during the performance. Part of that is during the 2017 performance period. And if you meet it in either of those, you're excluded. So if you met it in that earlier period and then you don't meet the low volume exclusion in the second period, it doesn't matter. If you meet it in either of them, you're able to take it and be excluded from the program for that year. One of the other things CMS is going to do to help providers really understand how they fit into the program is they're going to, similar to meaningful use, they're going to provide a system where you can go in and log in and see if a particular provider is excluded from MIPS based on the low volume threshold or not. And if you are excluded, eligible clinicians have the option to voluntarily submit information. We'll talk through some of the kind of risks and maybe potential benefits of that through the rest of the conversation. The other thing I would just mention, CMS also defines non-patient facing providers, and that leads to exclusions from certain things. For instance, the ACI category is going to be reweighted to 0. It follows a similar time period they're going to look at as far as those kind of two 12-month periods they can look back at. Those are important changes just to keep in mind as you're thinking about the programs moving forward. So just want to do a quick refresher on this as far as the kind of how the program works. Very similar to meaningful use. It's a 2-year look-back period. So your performance in 2017 is going to determine your payment adjustment in 2019. It's similar going forward. So 2018 is going to determine your payment adjustment in 2020. Got the dollar figures here moving forward. So again, happy to answer any questions there, but none of that changed through the final rule process. So as you know, under MIPS, you have two options for reporting. You can either have ECs report individually, so everybody, all the providers in a particular practice would have to report individually on their performance, or you can do group reporting, and that's based on, a group is defined as 2 or more eligible clinicians who have reassigned their billing rights to attend. So one of the important things that CMS clarified here around group reporting in the final rule is that if you choose the group reporting option, all of the eligible clinicians under that TIN have to report together. So you couldn't cherry pick out providers who are performing poorly and have them report individually through the group reporting option. So that's something some health systems were thinking about. And some folks were thinking about how to potentially take those approaches, but CMS clarified in the final rule that you can't do that. If you're doing group reporting, everybody's in, or you got to go the individual route and report everybody individually. The other really important thing to just keep in mind through this that I think gets lost in the conversation sometimes, based on the way CMS defined an eligible clinician, they defined it as a TIN NPI combo. So a single provider can have multiple instances that they're going to be assessed under the MIPS program, because each unique TIN NPI combo that they participate in is eligible to be assessed, could have different payment adjustments based on your performance under those different TIN NPI combos. So important stuff to keep in mind. Another just note for group reporting, even if a eligible clinician is excluded from participating in MIPS for a particular year, you're still going to have to report on their information, and it's still going to count towards your score. So it's a little different than how this has been approached in some of the historical programs. So important to keep in mind, just because somebody's excluded, if you're doing group reporting, you're still going to care about how they're actually performing on the measures, because it's going to impact your overall performance. And also here, if you submit information on a provider, eligible clinician, or one of the providers who's going to be eligible in 2019 potentially, that can also be calculated. If you submit that as part of your group reporting, that will be calculated into your score as well. So again, just important things to keep in mind as you're thinking about your strategies. And virtual group option for reporting, CMS did not provide that in 2017, but they're planning to implement that in future years. So one of the other really big changes that CMS made for the 2017 reporting period, they heard a lot of concern from stakeholders that there just wasn't enough time to prepare for the MIPS program based on the timeline for the finalization of the rule. So CMS tried to lay out an approach that's really going to help providers participate in the MIPS program. So we think about it in kind of three ways you can think about how you want to participate. If you don't participate, if you don't submit any information to CMS, you're automatically going to get a negative 4% payment adjustment for not participating in the program. If you submit a small amount of data for 2017 and you do that based on a 90-day performance period, you will, at worst, avoid a payment adjustment, so you get a 0% payment adjustment. You could potentially get a small positive adjustment. So that could be as simple as reporting one quality measure, participating in one of the improvement activities. We'll talk through some of this, but again, it's a very low bar that CMS set for avoiding that negative payment adjustment. And then if providers are hoping to get a larger payment adjustment, it would be, the approach there would be, again, 90-day reporting period required. But if you participate in all the performance categories and submit information, you have a greater likelihood of getting a higher bonus. Again, since this program is budget neutral and you're being compared against the performance of all the other participants in the program, it's a little hard to say at this point how you're going to do based on your performance. But if you, at a minimum, you know how to avoid a negative adjustment for 2017. So those are the really big important things to keep in mind for that. Also, would just note for 2018, CMS current proposal is for quality and cost to be year-long reporting periods. And for ACI and the improvement activities, it'll be a 90-day reporting period in 2018. So as far as calculating your score for 2017, CMS made a few modifications to the weight. So the quality category weight increased to 60%. They zeroed out the cost category for 2017, so providers are not going to have to worry about that. And they made some changes to the ACI measures as far as what's included in the base. We'll walk through all that on the coming slides. The other just important thing to point out here, for the quality category, CMS modified the rules such that if you submit a single quality measure, you're going to get 3 points. And those 3 points from submitting that one quality measure is what allows you to avoid the negative adjustment for 2017. So we'll jump through these really quickly as far as some of the details in the 4 performance categories. So CMS modified the requirements for the number of quality measures that you have to submit. So now for most eligible clinicians, it's going to be 6 quality measures that they have to report, assuming there are 6 that are applicable. CMS has also established specialty and subspecialty measure sets. So, for certain specialties, there's only 2 or 3 measures that CMS has identified that is applicable to them. So if you're part of that specialty and you submit those measures, you're eligible to get the full set of points for the quality category. They also dropped 2 of the kind of 3 broader-based, claims-based measures that they were proposing to calculate for providers. And the one they kept was a readmission measure that's focused only on groups of 16 or more providers moving forward. So those are some of the, the other thing to just keep in mind for the quality category, your performance is benchmarked for each measure on the performance of your peers across the country. So any other provider that picked that particular measure, you're going to be benchmarked against. For measures that have historical data, the benchmark is going to be based on historical performance data. Where historical performance data doesn't exist, so for instance, new measures or measures that they changed, your performance is going to be based on the performance of all other providers who are submitting that measure for the performance year. So 2017, if it doesn't have historical data, you're going to be compared to your peers for the 2017 data. And there's no banding of that. So for instance, a 1-doc practice is going to be compared against a large health system for their performance on those measures. So another thing that I think is really important, particularly for the health IT community, CMS provided a lot of clarity of how you can get performance or bonus points for using CERT under the quality category. They require end-to-end reporting. And, this is going to be similar to a lot of the ways you've thought about some of the meaningful use requirements in the past. So the data has to come out of CERT. and there's different options you have for reporting it moving forward, as assuming it comes out of the appropriate certified technology. Again, that's something we can certainly talk through in more detail, but you can get up to 10% of bonus points for that, doing that end-to-end electronic reporting. So the ACI category, a lot of this stayed similar. They made some tweaks as far as the number of points and kind of what's included in the base score. But again, there's a base score. You have to at least perform, you have to at least do each of the base score items once to get a base score. If you don't, say you miss one of those base score measures, you're going to get a 0 for the ACI category across the board. So really important to focus on ensuring your providers are meeting at least the base so you can get a score in this category. And we'll talk through some of the details. So for stage 3, they changed it so there's 5 base measures that you have to perform outlined here. You still have the similar structure of the 10% bonus performance score for those measures, and that is based on your performance for the category. So for instance, with providing patient electronic access, say if you do that for 1 to 10% of your patients, you're going to get 1 point. If you do 11 to 20%, you're going to get 2 points, and so on, moving up the chain. So that's how they do the performance score. You're going to add up all of your points for that, add it to the base, and add it to any bonus points, and that's how you're going to get your final score. But really, this stayed the same. It's the stage 3 measures. The other thing to just note, they changed. One of the things that used to be part of the base was the immunization reporting. They moved that out. It's now part of the performance category. You either do that or you don't do it for immunization reporting. So there's no, you can't get like 5 points for that. You either do it or you don't do it. They also changed their approach to the bonus points. So here's if you report to other public health options, you can get up to you can get a 5% bonus there. And they also established a process where if you use CERT to perform certain improvement activities, which is one of the other performance categories, you can get 10% bonus points for doing that. Got the next slide walks through what those are. We're not going to talk through them on the call today, but certainly could answer any questions on that moving forward. But there are a variety of options that providers have to use CERT to get those additional 10% bonus points. Also important to keep in mind, for 2017, providers have the option of using the, as they call it here, the ACI transitional measures, which is really the modified stage 2 proposal set of measures. So in 2017, providers have the option, if you take this path, you can use 2014 edition CERT. You could use 2015 edition CERT as well if you have it in time, or a combination of 2014 and 2015 edition CERT. Here, the really notable change is for the performance score to ensure that you can get up to 90% for the stage 2 measures as well. They increased the provide patient access and health information exchange to allow up to 20% of a bonus score, because the previous proposal, there were less performance measures that you could participate in if you were doing the stage 2 measures. So to make that even out between the stage 2 and stage 3 measures, they increased those to 20%. Bonus points are really treated similarly. It's just the different public health options you have under the stage 2 measures here as well. So the couple other things to highlight for the ACI category that changed, they've removed all of the exclusions under that you're kind of used to in the meaningful use program, other than for e-prescribing. They kept the 100 prescriptions there, and that's really important because some of the new provider types don't necessarily prescribe. So that's an important thing to keep in mind. As far as hardship exemptions, they're just handled now by reweighting the ACI category to 0. The other thing important to note here is they changed the definition of hospital-based EC. So historically, under meaningful use, it was a 90% threshold of performance in a hospital setting. They lowered that to 75% and also added a third point of service code for outpatient hospitals towards that. So the third category is improvement activities. They renamed that from the CPIA category. Not really many changes here. They lowered the total number of points you need from 60 to 40. So now you could do 4 medium weight activities to get you your 40 points, or you could do 2 high weight activities to get up to the 40 points, or any combination of those to get to the 40 points. 90-day reporting period, and there's a 90+ options of activities you can participate in to get these points. Some of them are based on participating in HIOs, QCDRs, really wide range of options. So providers have a lot of options there. The last category is the cost performance category. Again, this is weighted to 0 for 2017, so not something that folks have to worry about. But again, this is similar to the quality reporting category, where you're going to be benchmarked against all your peers across the country when they do actually start implementing this in the future. So the last point is just the data submission options. For each category, you have to choose one data submission option. If you're doing group reporting, everybody in your group has to use that same option. A variety of things to think about here. Certainly happy to answer any questions specific to that as well in the Q&A time. So with that, we'll turn it over to the question and answer period.
Thanks, Kory. So we have some questions coming in via chat. If you have questions, feel free to submit them via the chat feature. We're going to start going through them. I think use the rest of our time on that. We're happy to try and answer anything that you ask, though we may say that we don't have an answer. It's a complex rule, but the first question is a clarification on virtual groups. Could you clarify, is that referring to the CINs or ACOs or some other type of amalgamation?
So, the virtual group option is really aimed at helping small provider practices or small provider groups be able to potentially do virtual integration, right? So you could potentially work with folks who aren't necessarily in your geographic region to create a virtual group of sorts to kind of combine your forces. It's not related to the ACO or some of those other programs. It's really a distinct concept for the MIPS program. I don't know if you have anything you'd want to add to that, Genevieve.
No, I think that's correct. I think the virtual groups are pretty loosely associated with each other through contracting, and so it's not your typical setup like you share a TIN across the network. And so it's folks with various TINs coming together just for the purposes of support, reporting to the MIPS program. But as CMS noted in the rule, there's a lot of complexity to that because it's a net new concept. And so rather than starting that in 2017, they would like to start that in 2018. They are getting a lot of pushback from some federal folks, including, I think, the new head of HHS potentially, around not starting that till 2018, but that's the plan as of right now. Another question just came in. What are the new specialties that now have measures? So are there any new specialties? And I think the clarification might be on who's now eligible, or if you want to clarify that question, if you're referring to clinical quality measures. If you are talking about the quality measure category, they have broken up the quality measures into various specialties. So there's a specialty set of measures for almost every single specialty out in the marketplace, but I'm not sure. Yeah, it was quality measures. Okay. Yeah, so there's actually, I think, some upwards of 50 or 60 different sets of measures. Some have more than 6, some have less. Just depends on the specialty and how many quality measures they have that are applicable to them, and CMS intends to add to that list every year. And hopefully that answered the question. If not, let us know. Another question for you, Kory. What are some of the or could you clarify what the health IT requirements are that providers have to use both in 2017 and 2018? Sure.
So in 2017, providers have the option of either using 2014 edition cert, or they can use 2015 edition cert, or a combination of those two. So providers have that option for the 2017 reporting period. If you want to do the stage 3 measures, though, you do have to have 2015 edition cert. So some providers might be ready to do that in 2017, particularly with the 90-day reporting period now. Starting in 2018, all providers are going to have to move to 2015 edition cert to participate in the MIPS program. There's similar requirements on the advanced APM program. We'll talk about that in the next webinar next week. So hopefully that clarifies.
So is it possible to participate in MIPS if you don't have certified health IT?
No. You cannot participate in the program without certified health IT.
And for the other categories, quality measure in particular, are there health IT requirements for that category?
The broad requirement is to use cert. So you don't necessarily have to use it for the quality category, but again, as I mentioned, there are the bonus points available. So if you want to get those bonus points for using health IT, it has to be certified health IT. Similar with the improvement activity bonus points that you can get under the ACI category, you have to be using certified technology for that to be eligible. And there's, obviously some of the detailed requirements for the various approaches as well, but you have to have cert to be able to get those bonus points.
Great. Okay. Another question for the Advancing Care Information Score, where you get credited for sharing information with an HIE using an EMR, e-prescribing tool, et cetera. I think it's the measures. How does CMS audit the fact that you are meeting these best practices? Are there government agents in suits that come around and look at your behavior and practice environment? So I'll actually take this one because I've done a number of meaningful use audits. So what actually happens is that CMS contracts with an auditing company. Currently, it's Figliozzi and Associates, and it's random audits, theoretically. And so under the current Meaningful Use program, roughly 10% of providers and health systems get randomly audited. And then there's, of course, the audits that happen when there might be irregularities with the data that you submitted, or there have been a couple cases of whistleblowers where someone has called up the CMS hotline and indicated they think a practice isn't doing something correctly, in which case you will get hit for an audit. And what happens is Figliozzi sends you a letter, and they ask for basically demonstrable proof that you met the measures. And so depending on which meaningful use measure, or in this case, advancing care information measure, it will vary how you provide proof. So for example, if you said that, yes, I was working with an immunization registry and I was sending data to that immunization registry on an ongoing basis, all of the states will send letters to all of the providers who are contributing data to the immunization registry, and that letter is your proof that you were doing what you said you would do. Sometimes it's as simple as actually just taking a screenshot. And so when we had clinical decision support as a measure, sometimes you just had to take a screenshot that your clinical decision support was firing and working. Otherwise, it's actually the reports that your certified technology creates. So for measures like e-prescribing, to know the percentage of prescriptions that you e-prescribed, or transitions of care where you're sending a summary of care electronically, the audit is actually just reviewing the reports that your certified system creates, because most health IT is certified to create those reports. And so they'll review the reports. They might spot check a couple patients to make sure that it's actually showing in the patient's chart. But overall, that's kind of how it works. And so it's kind of people in suits, but not quite people in suits, because they don't show up at your desk. They actually just send you everything electronically. You submit everything back to them electronically, and typically you get about 30 to 60 days to respond to them in an audit situation. I would say that CMS has indicated that there will most definitely be audits under the MIPS program. Most likely those audits would be limited to the improvement activities category and the advancing care information category. Historically, CMS has not audited quality measures. They might, of course, start doing that, but they've not typically audited providers for quality measures. Okay. Any other quick questions? I got one more, and this will be our last question for the day. What is the impact of the current political landscape on MIPS and macro programs, your opinion? I'll let Kory go first.
Sure.
And I'll give an opinion.
I think macro was certainly passed with bipartisan support, so I think the broad framework is going to continue. I don't see that going away. I think we've seen the congressional support. I think you could see in future rulemakings, a different approach with some of these things. But I think for 2017, the rules that are in place are going to be the rules that people are going to have to perform to in 2017. There's just not enough time to make any tweaks to that. You could also start to see for 2017 the additional, if there is a desire for additional flexibility, a lot can be done through the sub-regulatory guidance, such as FAQs. I think we all saw that through the Meaningful Use program. You can do a lot of interpretation through sub-regulatory guidance. So that's my perspective. I anticipate it's going to stay the course for 17. I'm sure the new administration will have some different opinions for 2018, but we don't really know what CMS is going to do in 2018 now either, I would say.
Yeah, I would say 2017 is definitely set, particularly because CMS lowered the bar so significantly. I mean, literally, you submit one quality measure and you at least get a neutral score. And so 17 is going to stay the same. I think, one of the things some of us are a little bit concerned about is that Price, who has been nominated to be the head of HHS, has in the last few weeks expressed some concerns about the complexity of the MIPS program. He is a physician himself. He has very tight ties to physicians in the community, and I think he's hearing a lot of complaints over the complexity of the program. And so to Kory's point, I think the larger framework will likely stay the same, but there are places where the rule can be made less complex and made easier, and I suspect that's where they will actually try to take that course for 2018 moving forward. I think we all feel like ACA, the Affordable Care Act, is going to be the focus first before MACRA becomes the focus, so it's hard to tell what the timeline looks like. But either way, there will be another rule next year since we're in a final rule with comment period, so we can all expect some more fun reading. And then the last question was actually, can you reach out to us for more questions? Of course. Our contact information is up on the screen. It is also in the slide deck. We're more than happy to try and answer questions, and I just want to remind folks that we have 2 more webinar sessions coming up that you can register for. I think we're going to be sending out another email blast with the registration link for the second webinar, which will focus on the APM track. And then our third webinar will focus on how health information organizations can support MACRA. So we appreciate your time today. I think we might also be sending you all a poll to get some feedback on the presentation, and then you'll also get the slides and a link to the recording in an email shortly. But we appreciate you attending today, and we look forward to the next webinar. Thanks.